the arthroscopic assisted management of subchondral bone marrow lesions of the knee, the panplasty technique. The panplasty technique utilizes arthroscopic referencing and a guide system to access subchondral bone marrow lesions, all while minimizing the use of fluoroscopy, necessary in conventional methodology, where access is gained freehand towards an elusive target. This innovative approach allows precision and consistency, simplifying an otherwise cumbersome technique. The surgical technique consists of 5 basic steps. First is preoperative assessment and templating. Second, harvesting of biologics, arthroscopy, and identification of articular landmarks. Third, guide adjustment, placement, and drilling into the bone marrow lesion. Fourth, fluoroscopic confirmation and administration of biomaterials. The final step is repeat arthroscopy to check for extravasation. Step 1 is preoperative assessment of the lesion on a fat-suppressed T2 MRI. This includes noting the borders and associated articular pathology. Following this, the desired position of the delivery cannula within the bone marrow lesion is templated. The terminal point of the cannula is called the target point. The vertical distance from this point to the articular surface identifies the arthroscopic reference point. The tip of the localizing probe will be placed at this point during arthroscopy. Landmarks that help identify this location are noted and include anatomic structures or pathologic lesions. The placement of the localizing probe is then templated. The offset distance is the measured gap between the target point and the arthroscopic reference point. The angle formed by the delivery cannula and the localizing probe is called the access angle. The guide parameters will be set according to these measurements. In this case, the access angle was set to 50 degrees with an offset distance of 5 millimeters. It is the offset distance which allows for drilling into the lesion without violating the subchondral bone. Surgery begins with harvesting the biologics. We generally use bone marrow aspirate with DBM or graft from the anterior iliac crest, as this allows the procedure to be done with the patient supine and not having to change position for the arthroscopic surgery. Arthroscopy is then performed, addressing any intra-articular pathology, such as meniscal tears or chondral lesions. Attention is paid to anatomic landmarks which help reference the position of the bone marrow lesions, such as chondral lesions. The arthroscopic reference point is then identified based on the template, which may or may not coincide with chondral lesions. The panplasty guide is now adjusted on the back table. It consists of the frame, delivery cannula, and localizing probe, and the respective housings. The housing for the localizing probe can be translated linearly, while the one for the delivery cannula can be translated in an arcuate fashion. The offset distance and access angle are set per the preoperative template. The localizer probe attached to the preset guide is then placed on the arthroscopic reference point, generally through the contralateral portal. The delivery cannula is then passed through its housing to indent the skin at the provisional entry site. It is then withdrawn and the guide rotated slightly away, taking care to maintain the probe on the arthroscopic reference point. A spinal needle is placed through the indented area to palpate the bony cortex and identify the optimal entry point into the bone. A small stab wound is made in the skin through which the delivery cannula is passed, maintaining the angle and placed against the bone. The guide is then rotated back with the housing open to encage the delivery cannula. The slot is then closed and now serves as a drill sleeve. Drilling is then performed to enter the bone marrow lesion with precision and consistency. At this point, fluoroscopy is used for confirmation rather than targeting, thereby minimizing cumbersome positioning and radiation exposure. Fine-tuning may now be performed as well. Once the desired position is confirmed, selected materials are administered through the lure lock mechanism, utilizing either the end delivery or side delivery cannula. Bone grafting may also be placed through the end delivery cannula. Finally, repeat arthroscopy is performed to check for extravasation and complete the procedure as necessary. Here's the follow-up evaluation of the case presented, demonstrating significant improvement on MRI and clinical resolution of symptoms.